X-Tack wound closure, insertion tips and pitfalls. The experience with this wound closure system that led to this video was obtained by doing an investigator-initiated and designed ex vivo porcine colon study that was supported by the device's manufacturer, Apollo Endosurgery. Non-sterile X-Tack devices, sclerotherapy needles, and frozen porcine large bowel specimens were provided by the company. No financial support was provided. The Northwell Advanced Endoscopy Lab provided all other equipment and disposables. The endoscopic removal of large sessile adenomas via EMR and ESD results in sizable mucosal wounds. Although not mandatory, most endoscopists, where feasible, prefer to close polypectomy defects with clips in an effort to decrease post-polypectomy bleeding and delayed perforation. Also, if a small perforation is suspected, sound closure is necessary. Unfortunately, it is very hard or impossible to close many large defects using standard clips. In addition to standard clips that are delivered through the endoscope's working channel, over-the-scope clips are an option for small and some middle-sized defects. OTSC closures often include deeper layers of the bowel wall. These bear claw-like clips come in different sizes, but unfortunately they cannot be used to close large defects. The overstitch device permits full-thickness running suture closure of rectal and some sigmoid wounds, but can only be used in conjunction with a therapeutic double-channel upper endoscope. Furthermore, the overstitch has a lengthy and challenging learning curve. Most endoscopists are comfortable using standard clips. However, large mucosal defects cannot be bridged with clips unless used in conjunction with a double-channel scope and grasper. Unfortunately, double-channel scopes are not frequently used, and they are also not widely available. Further, few endoscopists are adept with over-the-scope clips or the overstitch device. Clearly, a closure method for large defects that can be used with single-channel colonoscopes is needed. Fairly recently, a new closure system that has been introduced that consists of 4 metal tacks joined by a suture that are implanted one by one into the mucosal edges of the wound. After placement of the 4 tacks, a plastic cinch on a delivery tool is passed along the suture and positioned over the wound. The suture is then pulled taut, which pulls the 4 tacks together and coapts the wound edges. While maintaining tension on the suture, the cinch is fired, which secures the closure. The Helix X-Tack system allows for closure of large defects and can be used with any length single-channel endoscope. Users must learn about the X-Tack system, which includes the tacks and suture, a tack delivery tool, plastic overtube, and a cinch device that secures the closure. Because each tack is individually placed, the delivery tool must be inserted and withdrawn 4 times, after which the cinch device is placed. The system works well if used properly, but the method is not intuitive and has a definite learning curve. There are best practices to be adhered to and pitfalls to be avoided. The metal tacks are 6 millimeters long and have a threaded helical screw at one end. There is an eyelet mid-tack through which the suture passes. A knot prevents the suture from being pulled out. In addition to the delivery device, there is a plastic sleeve that protects the scope. The delivery device is preloaded with the first tack and comes already inserted through the sleeve. The handle of the delivery device is a Persian drill, which when manually closed rotates the rod attached to the screw. Provided the delivery device is being pushed into the mucosa when the drill handle is closed, the rotation will screw the tack into the wall. After a plastic bracket that comes with the kit is mounted on the scope handle, the plastic sleeve and delivery device are inserted through the instrument channel. Next, the tack card must be mounted on the scope bracket. Prior to card placement, the distal shaft of the delivery device must be released from the card, which is then easily snapped into the bracket. The plastic sleeve is fully inserted until the flange at the end of the sheath sits inside the working channel's rubber cap. Next, the orange elastic band that stabilizes the delivery device is removed by pulling on the protruding rectangular tab. Once released, the delivery device can be further inserted. At this point, the first tack can be inserted. To do so, the scope is positioned over the wound edge and the delivery device further advanced until the tack is being pushed with some force into the target area. Ideally, the tack should be 0.5 to 1 centimeter from the wound edge. On command, the assistant closes the Persian drill handle rapidly, which should screw the tack into the wall. Once inserted, to release the tack, the blue button on the proximal end of the handle is pushed down and slid forward while the rest of the handle is held steady. This separates the tip of the delivery device from the tack. The delivery device is then fully withdrawn from the endoscope. After first resetting the handle, the blue button is pulled back to its original position. This pushes the tip out from the end of the delivery shaft, which allows it to be loaded with the next tack. The delivery device is then inserted into the plastic tack loading sheath on the card and pushed until the tip clicks into the tack. The loaded delivery device and tack are then pushed through and beyond the loading sheath and the tack card. The loaded delivery device is then reinserted. The assistant should hold the external end of the suture steady during insertion to prevent the suture from getting pulled into the scope. If extra suture is pushed into the channel, it can lead to tangling, mid-suture knot formation, and device failure. Once fully inserted, the delivery device and tack are positioned, forward pressure applied, and the Persian drill handle closed, which inserts the tack. The tack is then released, the delivery device withdrawn, the next tack loaded, and the insertion process repeated 2 more times until all 4 tacks have been placed. After the 4th tack, both the delivery device and the plastic oversheath are fully removed from the scope. The cinch that secures the closure is mounted on a separate delivery tool. Prior to cinch insertion, the external end of the suture must be passed through the thin orange plastic threader loop that sits just proximal to the plastic cinch. The flat tab of the orange threader is then grasped and tugged, which pulls the suture through the tip of the delivery device. Next, the end of the suture must be held steady while the cinch device is passed through the scope into the colon. The scope tip should be positioned so that the entire wound can be seen at the bottom of the monitor. The cinch delivery device is inserted beyond the scope until the plastic cinch at its tip is proximal to the wound. The distal part of the shaft of the delivery tool should also be seen on the monitor. While holding the scope and cinch steady, the external end of the suture is pulled tightly, which draws the 4 tacks and wound edges together. When the tacks have been pulled together as tightly as possible and while maintaining tension on the suture, the cinch device is fired by the first assistant who is holding the instrument's handle. Prior to firing the cinch, the handle must be opened a bit to release the plastic block that sits in the handle. After the block has fallen away, the handle is then fully closed, which is best done with 2 hands. This draws the cinch into the hollow tip of the device and then pulls the suture through the cinch, which secures the closure. The device also cuts the suture just beyond the cinch. The X-Tack system is an innovative wound closure approach. However, the proper placement of the tacks and subsequent cinch closure is a fairly complex and nuanced multi-step procedure. There are numerous reasons why wound closure may fail. The problems and issues that lead to failure fall into 3 categories. 1. Tack placement. 2. Suture management during tack placement. And 3. Insertion and firing of the cinch. What follows are use recommendations and consideration of the potential problems that can arise. A number of technique recommendations and pitfalls will now be discussed. The first concerns the importance of suture management. During wound closure, the tack delivery device is inserted 4 times and the cinch tool once. After the first tack, the delivery and cinch tool must be passed multiple times along the suture, which remains in the instrument channel. This provides multiple opportunities for extra suture to be pulled into the working channel and colon. When this occurs, suture loops or knots may form that entrap the delivery tool and lead to device failure. To avoid knots and loops, the assistant must hold on to the external end of the suture and prevent it from being pulled into the scope during device reinsertion. Since a loop can form externally before the device is inserted into the instrument channel, the endoscopist and assistant should check for loops and, if necessary, straighten out the suture before insertion. Tack position is a critical variable. It is recommended that the tacks be placed 0.5 to 1 centimeter from the wound edge. It should be noted that it is difficult to accurately judge distance endoscopically. Furthermore, it can be difficult to keep the tack at the chosen location since after pushing the tack up against the mucosa, it may slide away before implantation. The ideal angle between the delivery tool and the bowel wall is 90 degrees since it will lead to vertical insertion. Also, it is necessary to push the delivery device strongly into the bowel wall in order to stabilize the tack position and to maximize the depth of penetration. In the colon, in practice, the insertion angle is often more acute because the bowel lumen does not permit a 90-degree angle. Also, the more tangential the approach, the greater the chances the tack will slide prior to placement. Deeper penetration to the submucosa or muscularis propria layers is more likely to occur if the delivery angle is vertical and pressure is applied during insertion. In contrast, the tangential angle of insertion is likely to limit penetration to the mucosal and possibly submucosal layers. If tacks on opposite sides of the wound involve the muscularis propria layer, the closure will imbricate the bowel wall and create an outward buckle that is easily recognized from the serosal viewpoint. This is clearly more secure than a clip closure, which usually involves the mucosa alone. Although the goal is to place the tacks at least 0.5 centimeters from the wound edge, in practice, because the tacks often slide away from the target, they may end up considerably closer to the margin. Thankfully, as per an ex vivo study that the authors carried out, secure mucosal opposition can be obtained with tacks 2 to 4 millimeters from the defect's edge. Tack insertion may torque the mucosa around the shaft and obscure the view of the tack. To expose the tack to assess the implantation depth, turn the Persian drill handle counterclockwise while holding the delivery shaft stable. Continuing to turn the handle counterclockwise will unscrew the tack from the wall. Conversely, the tack can be further inserted by turning the handle clockwise. If the tacks are not locked into the delivery device, they may pop off the shaft and dangle loose on the suture. If this happens with the first tack, the entire scope can be removed and the tack manually reloaded. If it occurs after a tack has been placed, an attempt can be made to redock the tack in the bowel. If successful, it may be possible to manually screw the tack into the wall. The alternative is to leave the loose tack and move on to the next one. This mishap can be avoided by making sure the tack is locked onto the delivery device before insertion. There is a palpable click that occurs when fully seated. The X and Z suture patterns are most commonly used. In a recent ex vivo porcine study carried out by the authors, it was shown that the closures obtained using these two patterns were equivalent. In general, it is recommended that considerable progress along the wound be made with each tack. For larger wounds and in cases where a substantial open wound remains after a 4-tack closure, there is the option of placing a second set of tacks to close the gap. The other option is to use standard clips to close the remaining openings. After tack placement and prior to wound closure, the cinch device is inserted into the colon. The oval plastic cinch at the tip of the delivery device needs to be proximal to the wound and in the bowel lumen. It is possible for the plastic cinch to get lodged in the submucosal pocket, which will interfere with closure. Therefore, it is important to confirm that the cinch is in the lumen and proximal to the wound prior to firing the device. Before tightening the suture and firing the cinch, the scope should be positioned so that the distal shaft of the delivery tool is visible and positioned over the wound. It is important that the delivery tool be held steady when the suture is tightened and the cinch fired. Finally, prior to firing, it should be visually confirmed that the wound edges and the 4 tacks have been pulled together. A critical variable during closure is the amount of tension applied to the suture. It needs to be sufficient to draw the 4 tacks and the wound edges together. The tension must be maintained during the firing of the cinch. However, if pulled too hard, the suture can break, which will lead to device failure. This drawing shows excess suture being pushed into the colon as the delivery tool holding the 3rd tack is reinserted into the bowel. If a suture loop is created between the 2nd tack and the scope, it is possible to lock the suture, which will compromise the closure. Here we see the delivery device being passed through a fully formed loop prior to implantation of the 3rd tack. This results in the suture becoming trapped or locked beneath the suture joining tacks 2 and 3. Short of removing the 3rd tack, which is not an option, there is no way to unlock the suture. If the 4th tack is placed so as to complete the Z pattern, the lock will significantly impede the closure. Therefore, it is recommended that the 4th tack be placed so as to make an X pattern, which minimizes the impact of the lock. Of note, converting to an X pattern may necessitate the placement of a second set of tacks to close the remaining open part of the wound. By applying adequate traction to the external suture during 3rd tack placement, loops and a subsequent locked suture can be avoided. In summary, the X-Tack system is a welcome addition to the endoscopist's toolbox. This method allows closure of large wounds with tacks that penetrate into the submucosa or muscularis propria layer. This is an improvement over clip closure, which usually involves the mucosa only. Importantly, this system can be used with any colonoscope and does not require a double-channel device. Although far simpler and less demanding than the endostitch device, there is a definite learning curve that must be traversed by both the endoscopist and assistant. There are multiple components to the system and numerous insertion steps, as well as pitfalls to be avoided and best practices to be learned. Ideally, the initial exposure to the device and training can be done in a non-clinical setting using ex vivo porcine stomach or large bowel.